Hello, everyone. It's a great pleasure to be here and to organize this and welcome everyone from actually around the world. We have this opportunity because we have the Mathematics for Public Health, which is a group organized by Fields Institute. So early warning system is one subgroup of this big project. We're very happy to have Dr. Kumar Marty here. I would like to invite Kumar to give an opening speech.
Thanks, Junling, and welcome to everybody, both those who are in the room and those who are joining us online from around the world. It's delightful to have all of you here. It's also delightful that we're slowly opening up and being able to interact, cautiously, but beginning to interact in person. It's a real happy event, I think. Also a testament to the fact that all of you who are involved in the mathematical modeling did a really good job, that we came out okay at the other end. So I just wanted to say a few words. Firstly, to welcome you in two capacities. First, as director of the Fields Institute, and then as co-PI on Mathematics for Public Health. Many of you might have heard about the Fields Institute, but for those who are new or hearing for the first time or attracted to this because of the particular event we have here, we are about 30 years old. We are a research institute, a think tank for everything mathematical. And activities at the Fields Institute span the entire spectrum, from fundamental research to applied research, industrial research, and even commercial applications of mathematics. During the last few years, of course, we were heavily involved in the pandemic, contributing whatever we could in terms of mathematical ability to monitor and to model and to predict. And I think that served us well and served the province and even the country well, and perhaps even the world well. We were in that endeavor, we were actually partnering with 3 other math institutes across Canada: the Pacific Institute of Mathematical Sciences in Vancouver, the Centre de Recherche Mathématique in Montreal, and the Atlantic Association for Research in Mathematical Sciences in Fredericton. So it was a national effort to that. The Fields Institute itself is funded both federally and provincially. On the federal level, we're funded by all 3 councils, NSERC, CIHR, and SHRC. Provincially, we're funded by the Ministry of Colleges and Universities. We have funding also from the United States through the National Science Foundation and through the Simons Foundation. And also we have funding from generous private individual donors, such as yourselves. In terms of Math for Public Health, as I said, I'm co-PI along with Professor John Hong Vu, who I believe is on the call from York. Yes, he's there, I see him. And we have the privilege of sort of guiding this big project, again, a national project, more than 60 researchers across the country, 14 projects, of which Junling's and Jude and Bushra's project is one, namely the early warning systems. Of course, you're the experts in this, but early warning systems are pretty critical in terms of determining timely and effective interventions in public health issues. And so this is a really important topic. So I'm glad that we have had a chance to organize something in this. So once again, welcome to the Institute, welcome to the conference. I should tell you that for those of you who are here in person, but maybe even for those who are online, a sort of mantra of the Institute is to make this as pleasant an experience as possible, to allow people to focus as much as possible on the science. We have an incredible staff. Ben is there, the project manager at the back, and Zara is here, and there are other people to help also. So if you need any help whatsoever in terms of the administration, please don't hesitate to reach out. We want you to do excellent science and have excellent communication and an excellent experience and come back for more in the future. So once again, welcome, and I hand it off now to Junling.
Thank you, Kumar. Again, Dr. Kumar Marty is the director of the Fields Institute, and he's also leading the whole Mathematics for Public Health program. Sorry, I should have introduced earlier, but I think my evening flight just become a red-eye flight, so I'm sort of, my brain doesn't work really well right now. But Our keynote speaker today is Professor Stephen Morse. We're really glad to have Stephen here. Stephen is a professor at Columbia University Medical Center. Among many great achievements, he is actually the initiator the initiator of the ProMed program, which is actually currently the largest publicly accessible early warning systems. Stephen, thank you. Yours.
Thank you very much. And it's indeed a pleasure to be here. And I think we've all been affected by the pandemic. Can everyone hear me? Okay. Hello, everyone, and welcome. It's a special pleasure to be here in part because with the pandemic, this is the first time I've been on an airplane in 3 years. Just before the pandemic started, I was scheduled to go to Singapore and Kuala Lumpur to talk about emerging infections and go to the ProMed meeting in February of 2020. But, of course, I think we have to be good role models for what we do. So I haven't been able to get on a plane. Of course, that trip was canceled. Since then, I think a lot of things have been canceled. So it's really a pleasure as we gradually get back to normal life. But I think, we all warn everyone, and you all already know that, in fact, the virus, as people say, is not done with us yet. So eventually we hope that this pandemic will settle down to becoming another essentially endemic coronavirus like the 4 others we already know about. But I have no guarantee we're there yet. And perhaps this is a task for all of you in Mathematics for Public Health to try to predict how we might better be able to do that. And what I want to talk about today is really just the matter of how infections emerge and some of the surveillance and other efforts we might do to stop them. And there's really a very simple message I have here, which is that surveillance and early warning are essential. They're necessary but not sufficient, as we saw with this pandemic and as we've seen in other cases. So what I want to really do today is just set the stage a little bit, get us all on what metaphorically in America we refer to as being on the same page. So this will probably be familiar to many of you, in which case you can hopefully enjoy some time off, but I'll try to be as entertaining as possible. Beginning with this New Yorker cartoon, and indeed it has been an interesting time to be an epidemiologist, and perhaps living in interesting times is not, as one of my colleagues used to say, the most desirable situation, but it certainly does keep us all awake. In terms of emerging and other infections, infectious diseases have had a tremendous impact on history. I don't think I need to tell you because we're all living through one of those impacts. And we've actually lived through several others, such as HIV/AIDS in the 1980s. And I'll have a few words to say about that. So throughout history, infectious diseases have really been major forces in shaping society and, in fact, major impacts on our own life and lifespans. You think of the Black Death, the plague in the 14th century, smallpox, the one human infection to have been eradicated, at least officially, and which no longer is circulating in nature. I think a very nice thing, that one success so far, and we hope there'll be others, but that still obviously is a work in progress. Cholera, which in fact made many people aware and made the public health community aware of the pandemic possibility of infections. We're still seeing cholera in many parts of the world, although in places like here in the beautiful city of Toronto, and indeed it's a pleasure to be here, and in my own home city of New York, the water is potable, and thanks to water purification, cholera is not the problem that it has become or has always been in the Bay of Bengal area, in Bangladesh, for example, and in many other parts of the world. The 1918 influenza I'll talk about in a few minutes, and HIV/AIDS, of course. So we're just a little over 100 years past the great influenza pandemic of 1918. And in fact, this was probably the greatest natural disaster in all of recorded history. There are at least 50 million deaths, and about half the world's population at the time actually was infected with this virus. At the same time, it wasn't known until 1933 that it was actually a virus when an animal model was developed. And for a long time, people thought originally perhaps it was bacterial. Although we knew about viruses, people perhaps did not appreciate how influential they could be in shaping our lives in ways both known and unanticipated. The flu pandemic of 1918 was not only a great natural disaster, it was propagated through World War I and probably had a major effect on the outcome of that war as people mustered in throughout the United States, came to places like Camp Funston in Kansas, were then sent out to Europe, and the influenza, which probably was already spreading through Europe, this is still a controversial issue, how this originated, actually propagated throughout the armies of Europe in 1918, and in the First World War. The German General Staff at least credits the influenza pandemic for having brought the war in part to an end. But of course, it's overshadowed by the events of war. The unusual thing about the 1918 pandemic was not only its tremendous range and the number of people infected, but also the fact that young, healthy individuals were also among the victims. As you can see here at this army camp, these young, healthy recruits, all now laid up with influenza, and sadly, a number of them would die. And that made influenza obviously very much at the top of our list of pandemic concerns. And in fact, we've had a number of pandemics since then. 1957, I actually personally had the flu in 57 and 68, which says something, I guess, about my own age. I did miss 1918. I was born afterwards. So, however, the 57 and 68 pandemics, although severe, were not like 1918, which to this very day remains unique. On the other hand, we all wonder, what could be waiting in the wings. So we all fear the return of something like a 1918 event, although we've never yet seen it. It reminds us that we really can't afford to be complacent. Our last influenza pandemic was 2009, and some people thought that perhaps it was a mild pandemic, a little too mild to take seriously, but in fact, people died, including young, healthy adults, and it was, I think, a reminder that pandemics still occur, and they still occur in many ways in unpredictable time periods. You can see there's no regularity. Perhaps this would be an interesting mathematical experiment. but we haven't found a real regularity to the timing of pandemics or indeed to their severity, and that's something we're still learning. In addition, other influenzas that we had taken for granted for a long time, avian influenzas, for example, have also recently become of greater concern and severity. However, what really, I think, focused our attention on our vulnerability to emerging infections was HIV/AIDS, as it's now called. It went, as you know, through many different names at various times initially, and it was quite a tragic and upsetting event. Those of you who may have the opportunity to see some footage from that period, perhaps the book or the film And the Band Played On, or the play A Normal Heart, will have a sense of the surprise and panic, because this was totally unprecedented in many ways, with which HIV was first presented itself. And as you can see, HIV not only appeared suddenly, but it really took off. Probably Elon Musk would be very happy if his SpaceX vehicles could achieve this sort of trajectory. But it took off to be a leading cause, in fact, the leading cause of death in young, otherwise healthy adults aged 25 to 44 years, and by the early 1990s surpassed all the others in its rapid ascent to infectious disease pandemic stardom. And that is a matter of great concern, because I think any time, as in the 1918 flu, one sees young, healthy adults becoming infected, but not only infected, dying in disproportionate numbers. These are people who should be in the prime of life, should actually having survived childhood. You can see the other causes of death. So they really should be healthy and able to withstand most infections, as we all have. That's why we're here today. And so an infection that can claim the young and healthy, as 1918 influenza did, as HIV did, are matters really of great concern. There is a second chapter to this, thanks to the development of effective antiretroviral therapies, the infection has been brought under control, at least in places where there is access to the medication. But prevention is still the best way, obviously, for dealing with it. However, if we're able to sustain this effort, it's quite possible that with luck and real dedicated effort and political will, a term you're going to hear again and again and as a subtext in this talk, we may in fact be able to eliminate HIV, not eradicate it because it still exists in nature, but to eliminate it as a human disease and control it within the next generation. That's something I think we can aspire to, but I'm not sure we'll actually be able to maintain the momentum and the success we've had so far. Of course, right now, what's very much front and center are the coronaviruses. Had this been a longer talk, it's probably going to be long enough as it is. I would show you all the photographs and other things of coronaviruses. But suffice it to say that in fact, they've been known to the veterinary profession for some time, and were first identified as animal diseases, non-human animal diseases, in the late 1930s. But then in the 1960s, human coronaviruses were identified and named as coronaviruses. That was a name because the projections on their surface sort of looked like solar flares or a solar corona. And June Almeida, who worked on this in the UK with colleagues, I think coined that term. And so the 3 human coronaviruses we've seen in the last 3 decades, there are 4 that are known to circulate regularly, but they've really been sort of ignored. In fact, until the 1960s, we really didn't even know they existed because they cause flu-like illnesses or mild colds, things like that, the sort of undifferentiated respiratory infections that we all tend to get during the winter. And they do circulate widely. However, 3 of them came to our attention very suddenly in the last 3 decades, beginning with severe acute respiratory syndrome from China in 2003, spreading around the world and causing about 9,000 cases with about a 10% case fatality ratio, about 900, just under 900 deaths. And in that case, it was largely through the healthcare system, through breaches in infection control, including the outbreak here in Toronto, which was a secondary outbreak after China. And my friend Don Lowe was in fact in charge of infection control here in Toronto, and I think it was a very painful experience for him to see it at the time. But I think it teaches us that it's very hard to maintain perfect, really rigorous hospital and clinical infection prevention and control procedures all the time. Luckily, this was controlled by the end of the year, largely through improvements and great attention to infection control. And we haven't seen it back in nature in recent years. However, at the time, it was also recognized that there were a number of other SARS-like coronaviruses in nature. I'll come to that in a moment. And that about a dozen were identified at the time, all of which seemed to have great potential for possibly infecting human beings if they got into the human population. So we had warning that there were other SARS-like coronaviruses waiting in the wings, some of which would probably be even better adapted to humans. Unfortunately, we did not act on that, but declared victory after the SARS was controlled. Almost 10 years later, in the Middle East, initially in April 2012 in Jordan with a few cases, and then later in Saudi Arabia, where the virus was sent to some other places in the West, London among others, in the Netherlands, and was sequenced. So we have the complete RNA sequence. These are RNA viruses, was Middle East respiratory syndrome coronavirus. And that's still going around. It's known that some of the people who were infected, the primary cases, get it from camels, from contact with camels, which may be a secondary host, but about half of the primary cases are unexplained. Most of the other cases are actually also within the clinical setting. So again, infection prevention and control are critical there for those who go into the hospital. And here, this outbreak is still going on, but it's been overshadowed by the most recent, of course, called SARS coronavirus 2, the cause of the disease we call, or that the WHO called, COVID-19, coronavirus disease of 2019. And as the name indicates, it began in 2019. So these are the infections, some of which and others I'll be talking about briefly in the rest of this talk. But let me first, if it's not a digression, actually provide a few definitions. What do we mean by emerging infections? And some people might say they know it when they see it, and essentially, we do know it when we see it because we saw HIV, we saw flu pandemics, and we've been seeing this coronavirus and others. In a more formal sense, as an epidemiologist, I was originally actually a lab virologist, those infections could be defined as infections that are rapidly increasing in incidence, that is the number of new cases, or geographic range. And I recognize rapidly is in the eye of the beholder, but I think these have in fact come very rapidly and often suddenly. In a number of cases, these have been previously unrecognized diseases. I'm going to argue that some of them already exist in nature, but perhaps not in the human population, or perhaps only in small human populations, and suddenly have the opportunity to come to notice and become more widely distributed. And oddly enough, as Pogo, this was a cartoon character from my childhood, said, we have met the enemy and it is us, anthropogenic causes, things we do inadvertently actually may precipitate the emergence or spread of one of these emerging infectious diseases. And this is a kind of a laundry list, or laundry perhaps would not be the appropriate term unless you catch it from laundering infected bed sheets or linens. On the other hand, there have been a number of examples of emerging infections, even before Ebola in 1976, and the many Ebola outbreaks we've had since then. And of course, going right down to the flu pandemics I've mentioned, including the 1918, the biggest one of all, and the SARS coronavirus 2, COVID-19, still going on, although we hope soon to wind down if we remain careful and vigilant. And last but not least, Mpox, or monkeypox, which I'll say a few words about towards the end. This map just expresses the same thing graphically. This is from my colleagues David Morens and Tony Fauci, who's now become a national celebrity, and for good reason. He's done excellent work, and obviously in this very polarized situation of your neighbors to the south in the US, it's become he's become sort of a lightning rod for criticism, but he's also one of our really best scientific communicators, as well as someone who's made major efforts, not only with HIV/AIDS, and did a lot there to help the situation to improve, but with this current situation as well. Anyway, this is just shows you how many infectious diseases emerge or reemerge throughout the world. And in fact, no pandemic or emerging infection has ever been predicted. And I think it's fair, after the experiences we're having now, to say that none has ever been stopped yet either. I'll mention briefly the one that got our attention a few years ago, before other things like the current pandemic came along to obviously take pride of place, and that was the Ebola outbreak in West Africa in 2014. And like all of these things, it starts perhaps innocently enough with a notice from, for example, the World Health Organization. This is their disease outbreak news in March of 2014. And you can see that it sounds very bland and scientific, but look at those red flags. a total of 49 cases, including 29 deaths, which is pretty much what you would expect, sadly, for Ebola, which has a case fatality ratio, although it depends on which species of virus and on the circumstances. And then also, it mentions that this was a rapidly evolving outbreak, which should tell you very quickly that this is something that we should really leap into action and worry about. And indeed, after that March announcement, about a month later, you could see cases throughout, from Guinea, throughout this entire region, as people move throughout that region for various reasons. And in many ways, a little bit like that example of HIV, after that initial start, it rose very quickly to claim, in fact, something close to 11,000 deaths, I believe, was the final number by the time it was finally controlled. You know, and so this is something that we do need to be concerned about. Emerging infections have the potential, although we should not panic. They do have the potential to cause serious effects, and as we see right now, of course, to even shut down world commerce and other things in this very interdependent and interconnected world. So the question is, how do these infections emerge? This is something I became interested in when I was at the Rockefeller University in the late 1980s, and my colleague Joshua Lederberg, then the president of the Rockefeller University, asked me very innocently some questions about some viruses that seemed a little odd and so on, and just post HIV, and I started thinking about this issue, and like most microbiologists, you know, thought it was a matter of rapid evolution of these viruses, many of which are RNA viruses, unlike all the rest of the life forms which are DNA-based and use DNA as their genetic information, genetic material in their genomes, but RNA copying is inherently an error-prone mechanism, and so you get a lot of potentially rapid evolution and selection and mutations and other interesting events. And like most microbiologists, of course, that's what I thought of. In fact, it was a great surprise as I thought about the question of introduction, where these came from, to recognize that actually in most cases, they already exist in nature, at least in some clearly recognizable form, and find their way into the human population. And that was a surprise to microbiologists, probably not to people working in other disciplines like ecology and with arthropod-borne mosquito-transmitted and tick-transmitted infections. So I thought of this as a two-step process. People have added various steps. I might prefer three at this point. Some schema, various schematics have suggested 8 steps, but anyway, it doesn't really matter. It's whatever is easy for you to analyze. And beginning with the introduction step, many of these are zoonotic, that is, they come from other animals into the human population. And in fact, there are a lot of viruses out there and a lot of other pathogens, bacteria, fungi, what have you, that are a rich source of potential emerging pathogens. There's a great diversity of other species of mammals, and in fact, other species of vertebrates, most of which are the reservoirs or natural hosts for the infections we're concerned about. There are many species, and of course, many different pathogens they may carry. At one point, we tried, Simon Anthony and a group of us tried to estimate how many viruses there are, and that was in Nature, and that was just a rough estimate, but it was published in MBio some years ago, if you're interested in how many there are. It's not infinite, of course, but it's a very large number. And so it's a rich source of potentially emerging pathogens. And of course, what happens is they're there, but they may not come into contact with human beings. Changes in the environment or in human behavior may increase contact with a species, with some other species carrying its own natural infection, but one that has the potential to infect humans and provide the conditions for doing that. And obviously, these environmental changes provide a greater chance of frequency of introduction. And then you can think of food animals as well as wildlife as potential sources. So Mark Woolhouse and colleagues made an estimate of this some years ago and estimated that about 130 of the 177 recently emerged pathogens are in fact zoonotic, those that have at least appeared in the human population and been tabulated since, say, the Second World War or thereabouts, the last 60 years or so, 60 or 70 years or so. So that's a very large, and probably our data are sparse, so the number may be even higher, but that's obviously a very large risk. And in fact, ecological changes provide new opportunities for pathogens to find their way into the human population. This slide shows a number of them, and I'll leave my slides if anyone wants to look at them later as I go through them quickly. There's been a lot of interest in hotspots or geographic areas where there might be the greatest chance of this kind of risk introduction of a previously unfamiliar or unrecognized infection into the human population. And suffice it to say, these are usually areas of great biological or of considerable biological diversity, which also has an interface with humans, usually where there's a lot of activity, such as agricultural change, land use change, mining or other extractive industries that provide the opportunity for humans to interpose themselves into that natural environment. That's work by Peter Daszak and colleagues at EcoHealth Alliance, and it's been refined somewhat, but basically it depends, of course, what a hotspot is, depends on what kind of pathogen you're looking at. If you're looking at emerging pathogens coming of the sort that we're talking about today, then tropical areas, for example, where there's also an interface with humans, especially an increasingly turbulent one and an increasingly growing one or an increasingly larger one are the places where you might expect it. For things like antibiotic resistance or antimicrobial resistance, of course, you might be looking to areas where antimicrobials are being used, selecting for resistance in the target pathogens. Keesing and colleagues also did an interesting analysis from the literature of the various drivers. I call them factors, but they're really synonymous, and locations of emergence events from 1940 to 2005, and found that this does vary from place to place, but that things like land use changes and agricultural intensification are major factors or major drivers. And in general, almost always, these are events that change the ecology of a local environment. And that's why what we call One Health, really seeing that we're all in this together on this planet Earth, all of the living things as well as the environment are really in this situation together is really important, because so many of these emerging infections are zoonotic, crossing species, and many of the emerging infections of the future can therefore be found now in other animal species, although deciding which ones to pay attention to is a very important, how to prioritize that is a very important question. There are a number of roles of evolution, both in providing the great biodiversity of potential pathogens out there in nature, and of course in adaptation in the human population once perhaps one pathogen is introduced. And I think there are a lot of really interesting questions in the evolutionary area. And I think that does follow the idea of, as Darwin stated, of diversification, genetic variation with selection. However, there is a room obviously for a lot of thinking in that area. And humans are often infected, as I mentioned, through changes in the environment that increase contact with wildlife, or handling of food animals, or sometimes occupationally. And therefore, surveillance across species is really important. What are some of the common pathways? Wildlife contact, live animal markets and food handling, hunting, and healthcare settings with infection control. And so we don't know exactly how HIV entered the human population. There wasn't anyone there to document it. Obviously, we weren't even aware that we needed to document it, but it was probably the closest relatives to HIV are in chimpanzees, and the evidence suggests that it was the handling of infected meat, essentially. You can see this picture here that allowed humans to first become infected, and then eventually HIV was able, although it was poorly transmissible, it infects for a long time, essentially a lifetime, and was then able to transmit both locally and then, as we know, throughout the world. Livestock contact, of course, is also important in that respect. And one example might be the pandemic influenza, which is actually thought to be a reassortment of influenza genes. This actually comes in segments, so these are influenza gene segments. The natural reservoir, the library, as Rob Webster, a colleague now at St. Jude's called it, of influenza virus genes in nature is the wild waterfowl of the world. But pigs may be an important mixing vessel for pandemic influenzas, and then humans are more susceptible perhaps and can get it on, for example, a farm situation where these species are put together. We've heard about wild animal or live animal markets. This has been true, of course, important with avian influenza, but also the origin of SARS and probably the SARS coronavirus too, because the natural host of the SARS coronavirus and many others turns out to be bats. For a long time, bats weren't studied because they were difficult to study. And so now we're finding a lot of potential pathogens and real pathogens in bats. They're also among the most plentiful and diversified of all the mammals. And so this little horseshoe bat sold in live animal markets in South China is probably the natural host for the SARS coronavirus. And very likely a related bat are the natural host for a number of other coronaviruses and for SARS coronavirus 2, for example, although that obviously is an unresolved issue. The second step, of course, is dissemination and establishment and dissemination. Luckily for us, there are a lot of candidates, but very few are successful. They're just not able to transmit themselves or find the conditions to be transmitted, or they may not be able to infect humans in a stable way to establish themselves in a human population. HIV would have seemed like a very logical candidate for not going anywhere because it was so poorly transmissible, but in fact it had the opportunity through human behavior to find a situation in which it could be readily transmitted, and through the travel of humans around the world became pandemic. And it is easier to travel around the world before the pandemic anyway, with our enormous global aviation networks, travel everywhere, and of course the major issue, the question of the interdependence as we see in this, as we saw during this pandemic, of our economy and of our populations. So the world is becoming much more globalized. That's good in many ways, but obviously there are unintended consequences. Now, one of the most important factors essential for pathogen success is transmissibility, and this has been one of the hardest things to study. HIV is poorly transmissible except through certain routes, and to its luck, although our great misfortune, HIV was able to find situations in which it could get transmitted despite its poor natural transmissibility. It's not transmissible the way flu is, but can be transmitted through blood or close contact with bodily fluids and other activities. And so transmissibility is really essential for pathogen success, and there are changes in human behavior. I've mentioned HIV, and we've seen many others now that have made it possible for some poorly transmissible pathogens to become much more successful than we would expect. But there are still pretty transmissible pathogens out there, like the one we're going through right now, like influenza in many cases. And that's something that still needs to be, better understood in terms of its how that evolves, and the genetics and evolution of transmissibility are really poorly understood. So I think it's modeled mathematically very often after the fact. The coronaviruses are probably among the easier ones to predict. Flu has been quite tricky in terms of predicting not just host range, but transmissibility. And one question you might ask, are emerging pathogens with broad host range more likely to become transmissible human to human? And that's been discussed for some time and may well be the case. Well, the current pandemic, SARS coronavirus 2, the COVID-19 virus, is not the first coronavirus we've seen, but this is the first pandemic coronavirus during our lifetime. It's also not the first pandemic from a respiratory virus, because we've already discussed the influenza pandemics. And this particular pandemic started in the same way, with this very, sort of almost bland announcement from the World Health Organization on January 5th that there was that there were cases in China of some sort of unknown as yet pneumonia, and that there were 44 patients in the hospital with this, of whom 11 were severely ill. So I think that is a serious, that automatically should make you think this is a serious situation. And to me, the biggest red flag was actually in the last paragraph, where it said that it was not known, or they had not any evidence for human-to-human transmission or transmission among healthcare workers. And that is something that's surprising, because you would expect to see some kind of transmission. So I think at that point you might begin to suspect that this is really the making of what could become something very serious. And in fact, just before this came out, and the WHO credits ProMed, the program for monitoring emerging diseases that you heard about earlier and that we started in the 1990s to try to get a better understanding and hopefully action in terms of dealing with emerging infectious diseases. This is on the internet, and in fact, there was something picked up from the local press about this infection. So after that, of course, the press stopped reporting on it, and that was also picked up by WHO and led to the China office getting that information and reporting it. Within a month, this became not only disseminated, but became a public health emergency of international concern as declared by the WHO, which sent a mission to China to investigate this in January of 2020. And it was evident at that point that it was transmissible from human to human. So early on, it looked as if this were really a study or a tale of two countries, China and Southeast and parts of Asia, where there were a lot of cases, and then a few scattered cases elsewhere. This shows graphically a graph from Nature what the situation was. China was very rapidly having transmission of these infections and did quite a lot to try to clamp down on it. This has, of course, become highly controversial, especially now that the so-called lockdown has been, zero COVID policy has been abandoned. However, by March, the rest of the world far exceeded China and has continued to. And the reason for that was the failure to appreciate that although we were seeing symptomatic cases, the vast majority of cases, and that's still a question for mathematicians, I think, for all of you to try to better estimate, because it's still something I think that we're working on. The vast majority of cases were probably either pre-symptomatic or asymptomatic or mildly symptomatic, and therefore not picked up as cases. This particular triangle or pyramid actually shows influenza published before the COVID-19 SARS coronavirus 2 pandemic. But I think it gives you a good indication of the fact that the severe and clinical cases we were seeing were really only the tip of the proverbial, I'm sorry to use that cliche, iceberg. And yet it was very slow for much of the world to act on this. This shows international arrivals at Dallas-Fort Worth in Texas on March 14th. New York had its first death from COVID on March 13th of 2020. And at that point, things pretty much halted in New York City. March 14th, you can see these are essentially super spreader events. And in fact, that's what happened as the pandemic continued to spread. And this is the situation now, covered the entire world. And in fact, with many cases, this was the situation as early as September of 2020, just a few months after its initial 6 months after its initial, or 9 months after its initial recognition. This is the situation as of now. So it's slowing down, but it's still very much with us. And then, of course, Mpox or monkeypox came to on top of all of this, to remind us that we really weren't prepared for infectious disease outbreaks. I'll go through this very briefly, but this had long been known in nature, and occasionally cases were identified. There had been an ongoing outbreak of human monkeypox in Nigeria from 2017 on, and cases of monkeypox, or mpox as we now call it, which is not highly transmissible, but spread essentially through the same mechanisms as HIV, AIDS by and large, as HIV. And that spread rapidly throughout the world. And there are still parts of the world that, although precautions, immunization, other things have largely protected many parts of the world, and it seems to be winding down, there are still places that are experiencing increases. And one big question here is, what was it our interventions that stopped or appears to have controlled this particular epidemic, or was it the fact that it just might burn itself out naturally, as had been known in the past with mpox? And that's a question that still remains open. It may be a combination of these things, although I think prevention is the most important message. Obviously, there are other things. So let me very briefly summarize this part of the talk, and then I'll just spend a few minutes on the last part of the talk. That there are these factors or drivers in emergence, including ecological changes. Human behavior is very important. Related to that, travel and trade, and technology and industry, including food processing and healthcare. Microbial adaptation and change, of course, is most evident with antimicrobial resistance, but we can also see that with the many variants that have come about with SARS coronavirus 2 as the pandemic has proceeded. And of course, re-emerging diseases, to me, is a red flag that indicates, I'm sorry to use that cliche again, a breakdown in public health measures. When you see an infection that we thought had been under control suddenly flare up again, it probably means that we have, for one reason or another, have holes in our armor or in our protective and preventive measures. And so measles outbreaks, for example, as the result of unimmunized populations for one reason or another, we might call those re-emerging diseases, especially if they've been controlled or not with us for a long time. But they are really a concern, that our public health measures haven't been totally effective or haven't been utilized as effectively as they could be. Because we tend to get complacent once the crisis is over. And so one reason I was interested in this field, besides the challenge of trying to understand where these organisms were coming from and how they occurred, was obviously what an epidemiologist wants to do, is to try to understand what's happening and how the infection or the situation, the health situation, is changing. And so one of my favorite quotes is from Ray Bradbury. People ask me, the science fiction writer, people ask me to predict the future when all I want to do is prevent it. And indeed, prevention is very important because that's what we do in public health, and it's often the most effective thing. That mask wearing, for example, we have now learned really does make a difference. And it will also protect you against influenza, for example, and a number of other respiratory infections. So keep doing it, because that was originally recommended, in fact, as a preventive measure during, or protective measure during, influenza pandemics, and then was adapted for this situation when it occurred. Now, this slide very simply shows the benefits of early detection, and you can see that in the early parts I don't know if you can see the pointer, in the pink parts. So, basically, if you're able to detect and control an infection earlier or any health event, the sooner you can do it, obviously, the more lives you can save or the fewer infections you'll have. Back in the early 1990s, we became very concerned about the fact that we were so vulnerable to infectious disease outbreaks, and there was no real global system for surveillance of infectious diseases globally. And in fact, what we really needed with this pandemic was an effective surveillance system, but for a variety of reasons, it was never really implemented. And so we started something called ProMed, the Program for Monitoring Emerging Diseases. And one of the things we discovered was that the people all over the world who were involved in it, originally was seen as a network, had no way to communicate. So Josh Lederberg, an early adopter of all technologies, suggested we should get everyone on email. And if you did email in the early 1990s, you'll realize this was not a trivial exercise the way it is today. The web is a very different thing, and the internet is a very different thing. But in fact, we did that, and it grew into not only a communications mechanism for the 60 or so colleagues throughout the world, laboratories and institutes, but also we opened it to everyone. It's a moderated listserv, meaning that technical subject matter experts are reading it and contextualizing the material that comes in from a variety of sources. It's free to everyone, no advertising, no support from, no commercial, or, they were very careful. The whole idea was that this was One Health based, so you will get both animal and human diseases if you ask for even the emerging diseases report, which is the short version I get. It's free to everyone. They won't sell your name, at least last I checked. It started in 1994 and has about 70,000 subscribers in about 185 countries. This is what the website looks like, but if your inbox is a little bit sparse, should it ever be, you can also get it by email, as I do. And a number of first reports came through ProMed Mail, which we're now just calling ProMed for short, including the original report of SARS and some of the others I've mentioned. And we got a kind of backhanded compliment that from Stephen Johnston, who wrote a book I'll recommend on cholera about John Snow and colleagues in studying cholera in the 19th century in Victorian London, when we didn't even know about microbes as a source of disease. So it shows you the power of just plain ordinary epidemiology, finding out what the situation was and identifying the cases. And somewhere in the book, I came across this reference to ProMed, that it was the surely the most terrifying news source known to mankind. I think there are more terrifying things now, but back in 2006, it was a simpler world. There have been a number of other electronic systems developed since then. The world has changed to make it much more possible, including the Canadian system GFIN, which started a few years later, and when capabilities were, in fact, suddenly you could get things like news reports on the internet. Crowdsourcing reporting and using social media has also increased. And in fact, there are a number of applications like that, Flew Near You being one of them, developed by John Brownstein and colleagues, and apps that have been developed by WHO and others for contact tracing in this last pandemic. We've also been using genetics and genomics. And so early on, even with MERS-CoV, there was the use of genomic epidemiology to trace the relatedness of cases. This had been done for a long time with foodborne diseases and some others, but it's now obviously much easier to get genomes of complete viral sequences in a fairly short period of time. In fact, the genome of SARS coronavirus 2 from Wuhan was available within less than 2 weeks after the identification of the cases, and Eddie Holmes was able to get his Chinese colleagues to make it available to the world. So this has been useful for adding to our epidemiological shoe leather tracing, but also genomic surveillance. We can now look for variants and for other things using genomes and genome sequencing. Many of these are now available on GISAID and other open source databases so that you can do this yourself. This is just a nice diagram from CDC showing the mix of variants circulating during a period of time just before Omicron became the big one that displaced all the others. And it's interesting, as we've seen these variants emerge during the circulation of this virus, better, more fit variants have really displaced the earlier ones, more fit in most cases being those that were more transmissible. And people have been looking at other methods for testing. Wastewater testing, which has been used for polio as well, is now being used for a number of other infections, including SARS coronavirus 2. I see the airport has recently started doing it here. So the question with surveillance is, we'd like to think being forewarned is forearmed. But in fact, surveillance for early warning is still evolving. And as I mentioned, the real problem there is that we really need to have a systematic way of doing this. ProMed was an attempt to do that, but we really need a systematic surveillance that's well coordinated. And we saw the many holes, both in surveillance and then in response, that occurred with the this particular pandemic, which really could have been stopped much sooner, or at least slowed down by testing of asymptomatic individuals, perhaps initially coming in from places where infections were known, and doing regular surveillance. So this is a necessary but not sufficient first step. Responding appropriately and early is still a challenge, and doing it in a proportional way is still challenging, but political will and sustainability have turned out to be major issues. For example, post 9/11, the US made tremendous efforts in terms of smallpox preparedness, which provided the newer vaccines and the antivirals that were available for monkeypox, for mpox, but on the other hand, they were supposed to be stockpiled and immediately available, but after 20 years, it just couldn't be sustained. So thank you for your time. I've been a little long-winded, and I apologize for going a bit over my time, but I thank you for your time and attention. And I'll be here for the next today and tomorrow. Thank you. Okay.
Thank you, Stephen. Any questions from the audience? And by the way, sorry, just for if the online audience have any questions, you can just post in the chat window.
Yeah. One major question. I had a slide early on in the presentation.
That's for the benefit of all.
For the online people.
All the online people.
You had a slide early on in the presentation that was discussing high-risk areas in your heat map. And you noticed that the higher risk areas were China and India, as opposed to Brazil or Central Africa, where you'd have. So I noticed that there'd be two competing issues here. One would be live animal markets, probably in Southeast Asia, and the other one was land use change, which would be humans encroaching upon tropical areas or new areas. So I was wondering if that heat map was related to those two differences or if it was population based. Thank you.
Well, there are a number of things, and in fact, there was a more recent publication trying to reanalyze some of that. So the original paper is by Kate Jones and colleagues. Peter Daszak was one of the authors in Nature, and it actually had several different maps looking at what kind of risk you're considering. So this in particular is really the kinds of changes you're talking about, as well as, China and India also have not only a lot of land use change and diversity, also very large populations and growing populations. And that's something else that needs to be taken into account, because we're seeing more and more urbanization, and that may also bring infections from remote areas into the cities where they may be more likely to spread to other places, or also, as in the case of dengue, for example, a mosquito-borne infection, make an infection essentially become largely urbanized in what people might call urban slums, although that, I think is not, I hear that term used a lot, but in areas where the mosquitoes have a good habitat and they're very well adapted to humans. So it is rather complex, and human behavior has to be factored in there. I would refer people to the original paper by Jones et al. in Nature, which has some data as well as a discussion of how those maps, and a follow-on paper a few years ago by Christopher Allen, Toph Allen, and colleagues, myself included, at EcoHealth. Thank you for asking. It's still a question, I think, on which a lot of work still needs to be done, including, very importantly, human behavior, and that's often forgotten, as well as the other things that are easier to model.
A question about plant-based diseases. If there are some plant-based diseases which eventually infect animals, and animals eventually affect humans. So there is some multi-step construction here, and eventually we can counter that as well if we know more about plant-based ones.
I'm glad you asked that question, because in fact, ProMed Mill has a plant disease list as well, although that's separate. And it was in fact one of our colleagues at CDC, which we think of as really thinking about human diseases, that originally suggested it and advocated for it. We recognize how important it is, not just in terms of infection of humans and other species, but also because of the tremendous impact that a plant disease can have on human beings and on the environment and the animals on which we otherwise depend, but we depend on plant agriculture. And so it can have tremendous effects in terms of food supply, livelihoods, and many other things, as well as possible direct effects. So thank you for asking that question. They're often perhaps neglected, except among plant pathologists, but we tried at least to include them in our list, and we're always welcoming people to send in reports of things they have seen or are aware of any of these infections that seem to be unusual or new or appearing.
Thank you for your response.
Maybe we can
Thank you.
So maybe we can take a question from the Zoom audience. No questions, so thank you so much. Yeah. Okay, so for the slides, I think you will be sharing with us your slides, your presentation. Thank you so much.
It's my pleasure. Thank you.
Thank
And
you,
thank you
everyone.
all for